How's it going, guys? We have a 64-year-old woman today, history of slight puffiness beneath her eyes 1 week after treatment for UTI with TMPSMX, and she had a left-sided partial mastectomy for ductal carcinoma 7 years ago. Her mammography 6 months ago showed no abnormalities, non-smoker, non-drinker, BMI is 20. We have this histo here I'll talk about as we move through. What's most likely seen in this patient? Should I say BU creatinine ratio 22 is wrong? So a BU creatinine ratio greater than 20 means pre-renal azotemia, which is going to be when you have NSAIDs, diuretic use. It could be chronic congestive heart failure where the left heart is not perfusing the kidney the way you're supposed to. It can be severe dehydration, vomiting, diarrhea over many days. But the kidney, especially the PCD, is going to attempt to compensate for the reduced perfusion by reabsorbing more water. And the way it accomplishes this is by reabsorbing more urea and sodium where water follows. If you're pulling more urea out of the urine, then your blood urea nitrogen is high, which is why BU creatinine ratio is greater than 20. If you're pulling sodium out of the urine, then your fractional excretion of sodium is lower, which is why it's under 1%. This isn't pre-renal, wrong fucking answer. Choice BRBC cast is wrong. That's when you have nephritic syndrome, which is not the case here. Okay, so nephritic syndrome is a tetrad of hematuria, oliguria, azotemia, which means high BUN, and hypertension due to surge of RAS from the glomerular inflammation. So high yield diagnoses like Alport syndrome, PSGN, IgA nephropathy, membranoproliferative glomerulonephritis, diffuse proliferative glomerulonephritis, these are all nephritic syndrome. Wrong fucking answer. Choice C, increasing cholesterol, correct answer. So we have nephrotic syndrome here. Before I talk about the diagnosis, nephrotic syndrome is a tetrad of proteinuria. Number 2, hypoalbuminemia because you have the proteinuria. Number 3, peripheral edema because you have decreased intravascular oncotic pressure secondary to the hypoalbuminemia. And then number 4, dyslipidemia because the liver is pumping out apolipoproteins in order to compensate for the decreased intravascular oncotic pressure. So your LDL goes up, your triglycerides go up, HDL stays relatively the same. They just want you to know dyslipidemia. Things like the diagnosis here is membranous glomerulonephropathy, membranous glomerulonephritis, aka, and it's going to be the answer when you have nephrotic syndrome in the setting of solid tumors, miscellaneous, breast, pancreatic. It can be autoimmune diseases like rheumatoid arthritis. It can be sulfonamides like we have here, dapsone, gold salts. It can be obscure causes like primary antibodies against phospholipase A2 receptor. But the hypoalbuminemia is why we have the periorbital edema here. But I was going to say you can see it in things like minimal change disease as well in pediatrics. Okay, so high yield, the tetrads for nephrotic and nephritic syndrome. And this image is just, I jacked off Wikipedia, very buzzy for membranous glomerulonephropathy, where you just have an inflamed glomerulus. Okay, very eosinophilic, robustly. Means pink, eosinophilic. Okay, that's what we're looking at here. Let's just whip through the final ones real quick. Choice D, lumpy bumpy appearance on EM is wrong. That's PSGN. Obviously, type 3 hypersensitivity. You're going to have immune complex depositions, IgG, C3, depositing in a subepithelial fashion, where the appearance on EM lumpy bumpy, but the presentation is going to be when you have the pharyngitis, group A strep pyogenes, or cutaneous impetigo erysipelas cellulitis, followed by red urine 1 to 3 weeks later. Okay, and not to be confused with IgA nephropathy, which is viral infection, usually URTI. It can be gastroenteritis, not to be confused with HUS. But that can result in red urine 1 to 3 days later, not weeks. PSGN is 1 to 3 weeks later. Okay, but IgA nephropathy can be standalone, just red urine, or it can be part of the HSP, Henoch-Schilling purpura constellation, which is going to be palpable purpura in pediatrics, which is IgA vasculitis. It's a leukocytoclastic vasculitis where you get the immune complexes depositing in superficial vessels causing your palpable purpura. Number 2, IgA nephropathy. Number 3, arthralgias. Number 4, abdominal pain. Choice D, wrong fucking answer. Choice C, splitting lamina densa is wrong. It's Alport syndrome. Alport syndrome is a mutation in type 4 collagen, X-linked recessive. And that's going to be where you have red urine in a male who has an eye or ear problem because you have type 4 collagen and Never would have guessed it, the eyes and the ears. Not to be confused with Goodpasture syndrome, which is antibodies against type 4 collagen, aka anti-GBM antibodies. Wrong fucking answer.